that 67% of people in the United States are unhappy with their submental region. That's actually about the same number as people unhappy with their crow's feet. So we understand there's a need. People don't like submental fat. And the other interesting thing about submental fat is that skinny people can have submental fat. Young people, old people. So it's really an interesting spectrum. And one thing I will share with you, and having the opportunity to do some of these clinical trials in the beginning, is the fact that men don't like it either. So now we have a door opening to bringing and having the male patient come in for actually wanting some aesthetic rejuvenation with submental fat, which we've never had, because you know the ASDS statistics tell us that only 10% of the patients we treat for fillers are men and only 11% for neuromodulators. However, we're going to see quite a different switch with this, I believe, in the submental location. So that's why I think it's important for you to know about this, have it in your armamentarium, and be able to offer this for your patients. So the clicker is not working. I'm not clicking. Oh, there we go, clicking. Okay, those are my disclosures. I've done 4 clinical trials with this product, so I've been really involved with it since 2007 as it was developed. It's actually deoxycholic acid, and what that is a bile salt. It's a synthetic bile salt, just like you have in your gut, only this is synthetic bile salt, and I think that's a nice way to be able to explain to a patient. And the fact is, it's the only FDA-approved drug like this. It's first in class, which also made it very challenging getting it FDA approved because we had to show the 2-grade improvement, and it was really quite strenuous. And many, many patients have been treated, not only in the US, but globally. We know that when you inject deoxycholic acid, it actually causes adipocytolysis. What's adipocytolysis? The fat cell ruptures. And the good news is, when the fat cell ruptures, it's gone forever. So this is not a treatment where patients have to keep coming back year after year, generally speaking, because once you get rid of that fat cell, then the body reabsorbs it and it's gone forever. We know that it can actually make people feel like they lost weight all over just by reducing that submental fat. Now, we don't get something for nothing, right? There's a little downtime. You do have to tell the patient they may look like a bullfrog. And I assure you, some of them do. I treated my brother. He was so cute. He went to the grocery store the next day. He says, "My God, the kid looked at me and ran the other direction." So redness, swelling, sometimes a little hematoma is not uncommon, some induration, and then a funny kind of numbness persists, usually, and even up to 4 weeks. So in the clinical trials, we treated people every 4 weeks for up to 6 treatments. However, in real-life treatment now, many of the patients are only requiring 2 to 4 treatments in order to really have a satisfactory result that they're happy with. However, we've sometimes stretched it out to up to 6 weeks, because I think for several weeks more, they actually do get some decrease in fat even past that 4-week time as they're reabsorbing it and the inflammation goes down. So I've sort of stretched that out just as a thought. Now, when we evaluate a patient for submental fullness, we like to pinch. You need to make sure that there's actual pre-proximal fat there. One of the studies we did was in the 65 to 75-year-old patients, which I have a lot of, except most of those patients have skin sagging and skin laxity, and many of them don't actually have a lot of fat underneath there. So it was quite difficult to find those patients who weren't on anticoagulants, number one. And by the way, I never stop anticoagulants for any of these aesthetic procedures we're doing. I just tell them ahead of time, you may bruise a little more. So you want to make sure there is submental fat, and then you actually pull it down and palpate it to be sure that, and then grimacing is important because you need to document that they have no injury to their marginal mandibular nerve before you begin. We did have in the clinical trials, not my patient, but several patients who actually, because the marginal mandibular nerve, as I'll show you in a minute, actually comes over the antegonial notch right where the jowl is. It's like the forbidden fruit. You can't go there. The patient's saying, oh, I just like a little bit right here. Don't do it. That's where the marginal mandibular nerve lies. And we got paresthesias, and it actually was like looked like a Botox kind of effect where people had transient, only lasting up to 6 weeks, but still, they weren't very happy. So you have to be careful with that. And then you want to make sure, you're a physician, you want to really do a physical exam in that area, note that they don't have any lymphadenopathy, make sure you understand that they don't have any thyroid there, no scar tissue, again, that excessive laxity, because that patient's not going to have a good outcome. This is not inexpensive, this product, so you really want to make sure you have a home run and happy patients out in your community because they'll send other patients into you. You also want to look and see that whether or not the patient has a history of dysphagia. Document that they have no swallowing problems ahead before you treat. Also that there's symmetry, any asymmetry. Sometimes people have had facelift procedures and do have some asymmetry in that area. It can top off if they've had a little bit of liposuction, but maybe have a little irregularity. This is, again, another good location you can use this. Now, in terms of the anticoagulants, in the clinical trials, we could not treat people on anticoagulants, but in my everyday life, everybody in Bradenton's on an anticoagulant. So you just have to realize the only downside is they may have a little bit more bruising. And then in terms of pain, now this is a very debatable subject because my dear colleague Derek Jones came up with a concept that we need to inject local anesthetic prior to injecting the product. I don't. I'm telling you, I injected myself just to get a feel of it. It didn't hurt that much. And so if you give patients 2 Advil, 2 Aleve, something, non-steroidal anti-inflammatory, when they come into the office, and every patient who's made an appointment, by the way, for this in my office has actually gone ahead and had the treatment that day, once we explain the whole thing. So we give them the 2 Advil, and then they come into the room, and I find that and ice alone are really quite adequate for pain, and I think the more needles I put in somebody's neck injecting the local anesthetic, I mean, you can do it with a cannula, you can sort of tumesce it, but in my hands, and I'll demonstrate that later today, I don't use that injectable local anesthetic. Then you want to put on the grid, and you count the dots. It's very simple. I actually don't put the grid on, my assistant does, she's much better at it than I am, and so we do that. I actually do the marking, and I'll show you to define where we want to treat, and then she puts the grid on and we count the dots to determine how many injections, how much product we need to draw up. 1 vial of product equals 2 cc's. 2 cc's, 10 dots. 0.2 cc's per dot, so 1 cc, it's very simple math, even I can do it. 1 cc equals 5 dots. 2 cc's, 10 dots in a vial. The vials are actually overfilled a little bit, so it's intended for a single patient use vial. Now, reactions we didn't mention, there are some swelling. It's usually the most pain is right about 10 to 15 minutes immediate post-injection. And that's when they really get that tingling and a little bit of burning. But we have them sit there and hold the ice, and it really, on the scale, we're doing another study right now to look at real usage of the product. And patients are having a pain of 0 to 2, generally, on a 10-point scale. And then sometimes I will tell them to take some non-steroidal anti-inflammatories that night. There are some other people doing some injections of steroid at the time. And, just like the procedure I talked about yesterday, we tend to evolve in terms of how we adapt these products into our practice and what works for you. So you're going to pinch the skin, because by pinching the skin, you really have a feel for it. It has to be a sub-Q injection. You don't want to inject it too superficially because you will slough the skin. So when you inject, you put the needle in, you put your 0.2 cc aliquot at each dot, and then make sure that you stop injecting before you pull the needle out, just like we do with Sculptra, because you don't want to put any of the product intradermally or too superficially. Of course, in the clinical trial, the one patient that I did do that and got a little bit of a slough was a lawyer. But she didn't mind. She just put a scarf on and went to court, and it healed and didn't leave any scarring. So you really have to be careful to make sure that you inject the product at the right level. And this is what we're aiming for, is that preplatismal fat area. And you can see right here, the preplatismal fat is really very easily palpable. We also need to know, just like with other things, understand our neck anatomy. Most importantly, when we mark these patients prior to injection, you know exactly where the hyoid bone is, and then from the hyoid bone, a finger's breadth below that is the thyroid notch, and so you want to stay north of the thyroid. And this is really the angle that you're looking to improve, is that cervical mental angle, so you're going to be really way superior to where the thyroid is. We haven't had any complications with change in thyroid or problems at all. And this is the magic, is improving the cervical mental angle. And you can see right here that the cervical mental angle should be 105 to around 120 degrees of an angle, and that's what makes the beauty of the whole neckline and that's why you want to make sure that in your treatment area that that's the part that you're including. And then we know that other things are important to look at, the facial artery. The marginal mandibular nerve, the facial artery lies very deep, so we didn't have any problems with interarterial injections. However, because the marginal mandibular nerve comes back over the mandible at the antagonial notch. Does everybody know where your antagonial notch is? Here's your gonial notch at the angle of the mandible, and then medial to that, you can actually just anterior to the masseter, you can actually palpate a little notch there. And that's right where the marginal mandibular nerve crosses over onto the upper part of the mandible. The problem is there's a lot of variability with where the marginal mandibular nerve is. Usually it's 1 to 2 centimeters below the mandible, but sometimes it can be as much as 4 centimeters below. And that variability, it makes this a real danger zone that we have to delineate and we're careful to avoid. And then this is how we mark the patients, which you'll see later this morning when I actually do the injection, and we have our no treatment zone, and then we really can hone in and focus on the part where we want to. When you put the grid on, I actually take a little alcohol swab and remove the dots that are outside my treatment area, because you don't want to be drawn to that dot and accidentally inject in that location. But here's what it can do for people. I mean, this is amazing. At 45 years old, look at the difference. Now, that was 5 treatment sessions, and many times in the clinical trial, we used a lot of product because we knew we had to make sure we were, getting that 2-grade improvement in order to get FDA approval. But you can see how just improving that angle makes the patient feel like they've actually lost weight, even though their weight is stable. Again, look at this composite picture, a 55-year-old woman. This is a nice age group for this because they still have enough skin tightening. Now, you do see a little bit of skin tightening, and why is that? Because with all this inflammation that we get in the treatment, you actually see a little fibrosis. So if someone has submental fat and a small amount of laxity, you can predict and tell that patient it's likely that they will also get a little bit of tightening. And then you can see, look at this patient. Again, men, actually, I think I've treated more men than women with this product. They really like it. It's surprising to me how one man will then actually share with another patient that they've had this done and how happy they are with it. And sometimes, look at this patient, went from 170 to 179 pounds, actually gained weight, however, still sees significant improvement in his cervical mental angle. The product was called ATX-101 when we were in the clinical trials. This is actually one of my clinical trial patients. Again, you can see that just many times with 2 or 3 treatments we're finding, and even less volume than we injected during the trial. I sort of look at it as an analogy to remember when the Voluma trial was done, And people got 6.8 syringes. They got a boatload of it, right? Because that's what they had to do to make sure that they had a 2-grade improvement. The same was true with this. So in real life, it's expensive. It's not inexpensive. Cost